All right, we'll get started. Welcome, everyone, to the National Myeloproliferative Neoplasms Conference. The Leukemia and Lymphoma Society of Canada is proud to introduce our second presentation, Understanding Essential Thrombocythemia, ET, Diagnosis, Treatments, and Follow-up Care. In this session, Dr. Lynda Foltz, clinical professor at the University of British Columbia, co-head of the St. Paul's Hospital Division of Hematology, and chair of the BC Cancer Myeloid Tumor Group, will review essential thrombocythemia, diagnosis, treatment options, and aspects of follow-up care. Before we begin, I'd like to introduce myself. My name is Natasha Sani, and I'm the Community Service Lead for the BC and Yukon region at the Leukemia and Lymphoma Society of Canada. I will be moderating today's event. We invite you to type your questions and comments in our Q&A box of your Zoom webinar panel throughout the presentation. We have an LS staff team member who will be monitoring the questions, and at the end, I'll read some of your questions out loud. I'd like to remind everyone that due to the large number of participants and our limited amount of time together, we may not be able to answer all the questions. And also note that Dr. Foltz cannot answer specific questions about a person's health history or status. Lastly, today's presentation will be recorded, so you can rewatch it again on our website. As we come together from across Canada, we recognize that we are on lands of many Indigenous nations. We honor the First Nations, Inuit, and Métis people whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancers. Are you looking for specific programs or resources, but not sure where to find them? We're here to help. You can connect with the community service lead in your area to receive personalized assistance and get connected to the resources in your region. We can help listen attentively and with compassion to the challenges you're facing. We'll help point you to information specific to your type of blood cancer or treatment. We can help you get organized to manage and take charge of your care, identify services that would be beneficial for you as well. We know that having a diagnosis of essential thrombocythemia can be very overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. And as mentioned, you can access our one-on-one support to help you navigate the blood cancer experience. On our website, you will find tailored information and resources, including those specific to essential thrombocythemia. Our goal is to better serve the community and offer an improved experience. The information and resources on our website are tailored and presented in multimedia formats to address a variety of needs and preferences. This includes fact sheets, booklets like the ones you see on your screen, podcasts from our channel called The Blood Cancer Experience, and you can find hundreds of podcasts for people touched by blood cancer and many addressing challenges that people living with ET face. We also speak to experts about current topics such as treatments, diagnosis, and research. You can also hear personal stories from people touched by blood cancer. We also have information and resources to watch like previous webcasts and our animated videos. Please visit bloodcancers.ca to read, listen, and watch all of these great resources. Before introducing our speaker, we wanted to address an important situation for the MPN community, the Pegasus shortage. And to do that, we have invited Dr. Shireen Sirhan, hematologist at the Jewish General Hospital in Montreal and president of the Canadian MPN Group, to address you in this short video. If you have any questions related to the situation, please contact your doctor, the LSC, or the Canadian MPN Group.
Hi, everyone. I'm Dr. Shireen Sirhan. I'm president of the Canadian MPN Group. I'm a hematologist and an MPN specialist at the Jewish General Hospital in Montreal, Canada. I know that the Pegasus shortage has been incredibly stressful, and I want to start by recognizing the strength of this community, both patients and physicians, who have come together to advocate for a solution. Your voices have been powerful, and I sincerely thank you for your patience and your persistence. Because of our collective effort, Health Canada has taken an unprecedented step. For the first time, they have approved an exceptional importation of Ropeg, which is not a Health Canada approved drug. This is in response to patient and physician advocacy. This decision reflects the impact of a united front, patient, physician, and pharma working together to ensure continued access to treatment. We have been working on several next steps to help navigate this transition. Some remaining Pegasus supply, approximately 60%, is still available and is being redistributed across provinces to ensure fair access. A guidance letter has been prepared to help physicians make informed decisions on Pegasus use. Meetings with provincial authorities are planned to determine how ROPEG will be reimbursed and distributed, and we expect updates shortly. We will then issue a guidance document addressing the safest way to transition patients from Pegasus to ROPEG. I also want to take a moment to acknowledge the dedication of my colleague physicians across the country. Many of you have gone above and beyond, advocating for patients, adapting to challenges, and working through uncertainty. This progress would not have been possible without your efforts. I also want to thank Forest Health for their critical support in ensuring a rapid supply chain of Ropeg and for helping amplify our advocacy. There is still work ahead, but we are making progress. Thank you for your trust, your patience, and your continued advocacy.
It is now time to introduce today's speaker, Dr. Lynda Foltz. Dr. Foltz is a clinical professor at the University of British Columbia, co-head of the St. Paul's Hospital Division of Hematology, and chair of the BC Cancer Myeloid Tumor Group. Her area of special interest is myeloproliferative neoplasms, or MPN. She is a principal investigator for MPN clinical trials and an executive member of the Canadian MPN Group. Thank you for being here with us today, Dr. Foltz. I'll hand it over to you.
Thank you, Natasha, and thank you to the Leukemia Lymphoma Society for inviting me to give this presentation. And thank you to everyone for coming and joining us today. All right, let's see. Oh, here we go. It's working. All right, so as was announced, I'm going to be presenting today on essential thrombocythemia. And as you likely know, my colleagues are or will be presenting on myelofibrosis and polycythemia vera, the related blood disorders. So, with myeloproliferative neoplasms, there are three closely related blood conditions: essential thrombocythemia, which we'll be speaking about today, which is characterized primarily by a high platelet count; polycythemia vera, which has a high hematocrit or hemoglobin level; and myelofibrosis, which has bone marrow scarring or fibrosis and tends to have low hemoglobin levels and variable white blood and platelet levels. These conditions are all closely related. Although an individual person will be diagnosed with one of these conditions, they are closely related, and over the course of a lifetime, there can be transitions between the conditions. So, most people with essential thrombocythemia, the disease stays as essential thrombocythemia for their entire life. So, this stays steady as essential thrombocythemia for approximately 80% of patients. But for some patients, especially patients, this is only really in patients who have the JAK2 mutation, which we'll talk about again. So, with a small percentage of patients, it can in time gradually move from essential thrombocythemia to polycythemia vera. The other transition that can happen is for a small percentage of patients with ET can in time change over to myelofibrosis, and this would be called post-essential thrombocythemia myelofibrosis, which is similar to, but not quite the same as primary myelofibrosis, where it starts as myelofibrosis. And then, fortunately, very rarely the disease can progress. So, unfortunately, that it progresses, but fortunately, in only a very small number of patients, it can progress to the most serious type of blood cancer, acute myeloid leukemia. Very rare. So, we're looking at progression rates. This is lifetime progression rates of about 2%. So, flip that around, 98% of people, this is not happening. Okay. These three blood conditions, essential thrombocythemia, polycythemia vera, and myelofibrosis, are also related by the molecular changes that we can see. So this is a cell signaling pathway. So this is the body made up of cells. This is the cell membrane or the edge of the cell, and there are signals that are sent from the blood through the cell that causes the cell to grow and divide. And one of the signaling pathways is through JAK2. And in everyone with essential thrombocythemia, this JAK2 signaling pathway is overactive. And the pathway involves this TPO, which is a thrombopoietin, binding this MPL receptor, activating the JAK2, which causes activation of this signaling pathway. In ET, this pathway is overactive, and there are different mechanisms that it can be overactive. The most common mechanism for this signaling pathway to be overactive is due to a mutation in the JAK2 protein, this JAK2 V617F gene mutation. And this mutation means this JAK2 is active all the time and causing signaling all the time, causing the blood cells to grow and divide. Really important to note that this mutation is it's acquired as an adult, so you would not be born with it. It's something acquired during the course of a lifetime, and it is only in the blood cells. So if we were to check skin cells, other cells, hair cells, sperm, ovary cells, they would not have the JAK2 mutation. It is just in the blood cells. And so it's not something that can be directly passed on or that would be directly inherited, although in some rare families there can be an inherited increased likelihood or tendency to acquire the JAK2 mutation. So the JAK2 mutation is the most common of the mutations that we see in ET in about 50 to 60% of patients. And it's also a mutation we see in polycythemia vera in almost everyone and in about half of people with the related condition, myelofibrosis. The other mutations that can occur, the next most common one is a mutation called CALR. CALR, so the CALR protein, it usually is located in a different part of the cell, in this part of the cell called the endoplasmic reticulum, which is deep inside the cell. But when it becomes mutated, it can bind to this receptor inside the cell and then move out to the surface. So the mutation causes it to abnormally bind to this receptor, which it shouldn't, and then to localize outside of the cell where also it wouldn't usually be present. The mutant calreticulin protein causes this receptor signaling to be activated and activates this whole signaling pathway. So both the end result is activation of JAK2 signaling, but through a slightly different mechanism. And finally, some people with ET have a mutation in MPL, which is this receptor, which causes it to be activated directly. So those are the three most common mutations. We call them the driver mutations because they drive this JAK2 signaling pathway. Most people have one of the mutations. It's very unusual to have more than one, so these are mutually exclusive mutations. There is a subgroup of people who do not have any of these mutations, and in that case, there is still overactivity of the signaling pathway, but it's through a different mechanism that we haven't identified. So there is a subgroup of people we call triple negative who don't have any of these mutations and have a different mechanism of this happening that we don't yet understand. Okay. So with that background, it leads us to how do we diagnose essential thrombocythemia? So we think about essential thrombocythemia when the platelet count is persistently elevated. There are many reasons why a platelet count can be elevated, but if there's no other reason for the platelet count to be high and it's persistently elevated, it leads doctors to consider the diagnosis of essential thrombocythemia. And to make a diagnosis by the World Health Organization criteria, a number of criteria need to be met. So the first one is the platelet count has to be greater or equal to 450. So normal platelets up to 400. So platelets have to be elevated. The WHO diagnosis also requires a bone marrow biopsy. And on the bone marrow biopsy, the pathologist will look at the bone marrow cells under the microscope. And in essential thrombocythemia, there are characteristic abnormalities of the cells we call megakaryocytes. And the megakaryocytes are the cells that produce the platelets. So it kind of makes sense. There are too many platelets in ET, and the cells that are the most abnormal in the bone marrow are these ones that make the platelets. So there's too many more of these megakaryocytes than normal. They're enlarged, they look abnormal, and have some abnormal features. And this is what the pathologist would be looking for to see if the bone marrow is consistent in how it appears with with the diagnosis of essential thrombocythemia. And importantly, there shouldn't be substantial reticulin fibrosis. So if there is a lot of fibrosis, then we would be considering whether this is actually myelofibrosis because fibrosis is not a feature of ET. Also important to exclude other related blood conditions. So the other blood conditions of CML, PV, and primary myelofibrosis, and we're looking for one of these driver mutations that I described. So the diagnosis requires either all of these major criteria, or for people who don't have one of the driver mutations, then a minor criteria needs to be met with another mutation or change identified, or very close attention to exclude other causes of high platelets. One of the questions I often get is a bone marrow biopsy required? And the answer is to make a WHO World Health diagnosis of essential thrombocythemia. Yes, a bone marrow biopsy is required. It's one of the criteria that we just listed. And the reason for that, the reason why it's listed as a criteria, is that a bone marrow biopsy is the only way to definitively distinguish essential thrombocythemia from the related condition pre-fibrotic myelofibrosis. So in patients with overt myelofibrosis, there's fibrosis, and then it's relatively straightforward. But there is also another condition called pre-fibrotic MF, which is kind of partway in between ET and myelofibrosis, but it's actually myelofibrosis. And the blood counts and the clinical presentation can be very similar to ET. So the only way to definitively distinguish is a bone marrow biopsy. And the reason why it can be helpful to distinguish is that people who have prefibrotic MF are more likely to develop overt MF in their lifetime than people with essential thrombocythemia. So it helps give some information as to what to expect. It most likely wouldn't change treatment or management. It would just be for prognosis or knowing what to expect in the future. The other reason why we do a bone marrow is in some provinces, the testing for oh, sorry, this typo here. In some provinces, the testing for CALR and MPL can only be done on a bone marrow sample. So this is in BC, where I'm from. In other provinces like Ontario, they do have testing for CALR and MPL available on the peripheral blood, and this will be coming to most provinces soon. And it is, if a person doesn't have the JAK2 mutation, really important to be able to do the testing for CALR and MPL to confirm a diagnosis. So the answer is to the question is yes, a bone marrow biopsy is required for a WHO diagnosis. That being said, there are some circumstances where a bone marrow may not be done and a presumptive diagnosis of ET is made. And that would be particularly if a person has significant elevation of platelets, and a mutation, one of these classical mutations, JAK2, CALR, or MPL, identified on blood testing, and all of the features really, really look like ET, then in some cases, the hematologist will make what I would call a clinical diagnosis of ET without doing the bone marrow. And the reason that's considered is that the bone marrow can be an uncomfortable procedure for some people, and there are certain circumstances where we may not feel that it's necessary or would not change management. Okay, so I'm going to talk a bit now about what people experience with ET and what the clinical manifestations are. And I like to think of them in three main categories. So the first category is that with ET, there is an increased risk of thrombosis, blood clotting, and bleeding. ET is associated with a number of symptoms, which we'll talk about, and for some patients, enlargement of the spleen, although this is not as common as it's seen as in the related conditions, polycythemia vera and myelofibrosis. And then, as I mentioned, there is this small risk or this risk of progression to myelofibrosis or leukemia. So these are the symptom or the clusters that I think about in terms of what to expect or what to think about and how we might approach treatment. So we'll start with the thrombosis. So, patients with essential thrombocythemia are at increased risk of blood clots, and there are two main types of blood clots. Blood clots can occur in the arteries, which are the blood vessels that take the blood away from the heart, and this can cause a heart attack if it was to occur in the blood vessels supplying the heart, a stroke, or it can cause clots or a lack of blood supply to the periphery, so the legs primarily in peripheral vascular disease. Sometimes this can also affect the spleen if there's a small blood clot in the arteries supplying the spleen. Blood clots can also occur in the veins, which is the low pressure system where the blood is returned back to the heart. The most common is a deep vein thrombosis or a DVT, and this most commonly occurs in the legs. With a DVT, it would cause pain and swelling. So it could be either or both, but usually both pain and swelling of the lower leg. So if that were to occur, that's something that if were to occur in anyone, they should seek medical attention to get that looked at. And what's happening with a DVT is it's a blood clot in the vein that returns the blood back to the heart. So that is painful and causes swelling because the blood can't be returned back properly. There can also be pulmonary embolus, which is a blood clot in the lungs. So the blood clots from the legs can break off and travel up towards the lungs, leading to a pulmonary embolism or blood clot in the lung. And that would be that would present with shortness of breath and chest pain. There can be unusual blood clots in ET as well. There can be blood clots in the veins in the head. So, different from a stroke, which is a blood clot in the arteries supplying the brain, the cerebral thrombosis, it refers to blood clot in the drainage system from the brain, but would cause a headache and a severe headache. Um, and there can be unusual blood clots in the veins in the abdomen. So, just like in the legs, there are veins in the abdomen returning the blood to the heart. And if there's a blood clot there, it would cause significant abdominal pain. And this is kind of a unique clot that is rare in the general population, but has a higher incidence in people with myeloproliferative neoplasms. So, when we think about treatment of ET, one of the main goals is to reduce the risk of thrombosis. But people with ET, there's a wide variety, there's a wide spectrum of disease, and there's some situations in ET which are low risk for thrombosis, relatively speaking, and other situations are high risk. So, what we want to do with our treatment is tailor the right treatment for each person. So we have some ways of stratifying or determining what we think the risk is of blood clotting and then using that to adapt our therapy. This is the classical system. And I mention this is because some of the older clinical trials of treatment use this older system, and it's not that different from the newer system. So classically, we considered people low risk if they were under the less than or equal to 60 years old and no history of thrombosis. So it had to be both. And the high risk was anyone over the age of 60 or if they had a history of thrombosis. So either of these two things made an individual high risk. With the additional information we have with the molecular testing, we can now refine this a little bit. So there have been a number of different risk scores that have come out. The one in highest current usage is called the revised IPSIT thrombosis score. And this, you can see it's actually quite similar to the classic score because the two biggest factors that affect blood clotting risk are history of thrombosis and age. But the other factor that makes a difference is whether someone has the JAK2 mutation. So the JAK2 mutation relative to the other mutations has a higher risk of blood clotting. So our lowest risk group is people under the age of 60, no prior thrombosis, and no JAK2 mutation. And then we add in the JAK2 mutation, risk is up a little bit to low. Intermediate is people over the age of 60, but no thrombosis, no mutation. And then the highest risk group is over the age of 60 with the mutation or anyone with a history of thrombosis. And to give you an idea of these rates of thrombosis, so in this very low risk group, the risk of blood clotting is less than 1% a year. So it's pretty low. And even in the higher risk group, there's of course a range, but we're looking at risks of like 3 to 4% per year. So it's in some situations with previous thrombosis a bit higher, but in people receiving treatment, this is in the maybe the 4% range. So still significant, but relatively modest. I put over here to the side the other risk factor for thrombosis, which is traditional cardiovascular risk factors. So high blood pressure, diabetes, currently smoking. This does also impact the risk. It's just in some of the models, in this most recent model, it wasn't as strong a predictor as these other factors, but this is still really important. And we'll come back to these, especially as these are all modifiable risk factors. You can't do anything about age, history of thrombosis, or mutation, but excellent control of blood pressure, diabetes, and stopping smoking can make or actionable factors that can make a big difference for people. Okay, so this leads to finding the risk level of thrombosis helps to guide our therapy. So in patients, and this is taken from the NCCN guidelines, so the American guidelines that have been published for essential thrombocythemia treatment, for people with very low risk, for everyone, we should be managing the cardiovascular risk factors. For the people with the lowest risk disease, the benefit of aspirin is not well established, although for some people it's really important for managing symptoms, which I'll talk about in a minute. Um, in people with the low to intermediate risk, we recommend aspirin to reduce the risk of blood clotting, although there may be a modest increased risk of bleeding, but the benefit in reducing clotting far outweighs that. And then in people with high risk disease, we recommend risk factor management, aspirin, and then cytoreductive therapy. So, this is a general term that I will use to describe treatments that lower the platelet count. And we'll come back and discuss in a little few more slides, we'll discuss the details of the options that we have for cytoreductive therapy. Another concern with essential thrombocythemia is an increased risk of bleeding. And it's kind of a funny thing because, on one hand, we have the increased risk of clotting, and then to also have an increased risk of bleeding. But it is well described, and the types of bleeding can include nosebleeds that are difficult to stop, gastrointestinal bleeding, so blood in the stool, vomiting blood, urinary bleeding, increased bruising, and then bleeding after surgery. And this can be a concern. So there are definitely situations where someone doesn't have bleeding in everyday life, but then has a surgical procedure and has increased bleeding associated with it. And the reason behind the bleeding in essential thrombocythemia, it's kind of interesting because first of all, you there appear, and there's a bit of variability between studies, but it appears that the risk of bleeding is actually higher in people who have really high platelet counts. And seems like a funny thing because platelets are the blood clotting cells. So why would you have more risk of bleeding with higher platelets? But when there are too many of the platelets, it affects their interactions with other proteins. And because there are many proteins that are involved in the blood clotting system. And one of these proteins is the von Willebrand protein. And usually, this von Willebrand protein forms clusters or multimers. And when there are too many platelets, it disrupts this process. It affects the protein that helps to form these uh, cluster, these multimers. And so there is what we call acquired von Willebrand syndrome. And this is to distinguish from a hereditary condition where some people can inherit dysfunction of or low levels of this von Willebrand protein. And that is separate. So this is when we talk about von Willebrands in essential thrombocythemia, it's not inherited, it's an acquired syndrome relating to the platelets affecting the formation of von Willebrand multimers. And it's more commonly seen when the platelets are really high. So we can test for this with a measurement of the von Willebrand activity in the blood. It's a blood test. Oftentimes we'd find the antigen or the amount of von Willebrands is normal or close to normal, but in some patients the activity can be lower, and it's thought very low activity levels may increase the risk of bleeding, although again there's some variability in the studies. Shifting gears, the other feature of essential thrombocythemia that affects many people is symptoms. And there's been a fair bit of research actually in myeloproliferative neoplasms in terms of the symptoms that patients experience and in trying to measure these symptoms. And this measurement is important for the clinical trials because some of the medications, particularly for myelofibrosis and to some extent for polycythemia vera, part of their role is to help with the symptoms. So we have to have an objective way of measuring whether this is being accomplished. There was a development, a very rigorous scientific development of a scale for measuring symptoms in MPN. So, not just ET, but all the MPNs. And it includes this list of symptoms. And you so some of the symptoms are more prominent in people with myelofibrosis who tend to have enlargement of the spleen, causing this abdominal discomfort and early satiety, feeling full soon. So some of the symptoms are not as relevant to ET, but this score is validated and can be used to monitor symptoms objectively in ET and all forms of MPN. But I'd like to take a moment just to go through the symptom list in detail. So, the symptoms that some people experience are headache. And with headache, usual treatments for headache are, of course, appropriate. But many people find this low dose aspirin to be really helpful for ET related headaches. And some people need to take it twice a day. So, if once a day isn't enough, twice a day, but often that can be really helpful. There can be an itch in ET. So, this itch is classically an itch after water exposure, so bath or shower, but can occur at other times. Can be really troublesome. Lifestyle adjustments. So, some people shower quickly, some people find hot water better, cold water better. How not being vigorous with toweling off can make a difference. We can also try different antihistamines. And then medications that are usually used for depression can also be helpful for the itch. So, low doses of medicines like paroxetine for some people can be helpful. There's this symptom called erythromelalgia, which is a burning sensation and redness of the fingers and toes. Again, related to ET, often improves with low dose aspirin, sometimes requiring the aspirin twice a day. Cluster of symptoms of weight loss, symptoms related to the spleen and night sweats, less common with ET than with myelofibrosis. These symptoms can get better with some of the cytoreductive therapies we'll talk about. Fatigue, brain fog, difficulty with concentration. The fatigue's by far the most common symptom reported. Can be challenging, requiring lifestyle adaptations. And some people get benefit from the cytoreductive medications, but some people get more fatigue as a side effect of the medication. So it can unfortunately be a challenge people have. And finally, bone pain, less prominent with ET, but can occur. Pain medications can be used, and sometimes these cytoreductive medications can be helpful as well. And there are many other symptoms, so this isn't meant to be an exhaustive list, but some of this highlights some of the more common symptoms. Finally, there is the concern about the risk of progression to post-ET myelofibrosis. The risk factor, so there's a higher risk of progression with the CALR MPL mutation relative to the JAK2 mutation, but it can occur in either group. We would love to have a medication that would reduce this risk. It's been really challenging to know if medications to prove whether medications reduce the impact or the risk of progression. And the reason why it's been really challenging to know is because fortunately most people with ET never progress, and the people that do progress, it occurs late, so after 10 to 20 years of having the disease. So as you can imagine, it's very challenging to design a clinical trial to test a medication over a period of 20 to 30 years and have a comparator group and follow people for this period of time. Also, as treatments change over time, so it's been challenging to get the robust data to know which, if any, medications could potentially reduce this risk of progression, which is a goal that we would all have for treatment. because it takes so long to see progression, we try using other markers we call surrogate markers to signal improvements with treatment that we hope will also equate to a lower risk of progression, but we don't know this for sure. So the types of other markers we look at is to see if a treatment will improve the bone marrow morphology, so improve those changes in the bone marrow, or reduce the allele burden, which refers to how much of the mutant, how much of the mutate many of the cells have the mutation that we identified. But with ET, it's been a bit tough because in some studies these have correlated. So improvements in bone marrow and allele burden have correlated with less risk of progression, and other times they haven't correlated, and they don't always correlate well with each other. So it's still been a bit of a challenging area. However, all that being said, the medication that's shown the most promise in this area is the interferon alpha, and there's these two types of interferon alpha 2A, the Pegasus, and interferon alpha 2B, the Ropeg or Besremi, which is the newer medication that Dr. Sirhan was discussing. We'll come back to that. So now I'd like to talk a bit about the cytoreductive therapies, and we want to talk about when we use them, how we use them, and what to expect. So, cytoreductive therapies are recommended in patients at high risk of thrombosis, so in that higher risk category. We know that the cytoreductive therapies are effective at reducing the risk of a recurrent thrombotic event. So this would be what we call a definitive indication. Cytoreductive therapies can also reduce the risk of bleeding, particularly in people who have that acquired von Willebrand's or that very high platelet count. Now, there's some variability in practice. Myself, I don't usually just treat a number. So if a person doesn't actually have any history of bleeding, but their numbers are high, I won't necessarily recommend treatment, with some exceptions, like, maybe treatment temporarily if they're going for surgery. But there are other hematologists and other guidelines that do suggest treatment if the platelet count is very high, like over 1,500. So there's some variability in practice and recommendations regarding using cytoreductive therapy to reduce bleeding. And then finally, we would consider cytoreductive therapies if the symptoms related to ET weren't being well controlled by the other strategies that I mentioned previously. And some symptoms respond better to cytoreductive therapies than others, but that would be a consideration. There are other times where cytoreductive therapies are considering, like if the white cell count is rapidly rising, if the spleen is very large or significantly increasing in size. So there are some other sort of specific or special scenarios, but these would be the most common scenarios that we would use these cytoreductive therapies. And then when we're using the therapies, we have to think about what are our targets or goals when we're using them. So in some cases, pretty straightforward. If we're using it to treat symptoms, we want to see some improvement in the symptoms. When we're using it to reduce the risk of thrombosis, we usually try to get the white cell count and platelet count normal or as close to normal as we can. It's not always possible because sometimes they can cause other blood counts like the hemoglobin to go too low, but that's what we try to do. Although it is a funny thing because although with ET, the platelet count is high. There's an increased risk of thrombosis. We know these medications reduce the risk of thrombosis, but we've never been able to, in research, pin down a specific platelet number or correlate the platelet count directly with the risk of thrombosis. But that being said, all of the trials where study these medications, in the trial, patients were treated to try to normalize the platelet count. So that's what we try to do when possible in practice. With trying to reduce bleeding risk, it's not as necessary to be as strict with the platelets because it's more the extreme platelets related with bleeding or when those von Willebrand levels are low. So we can be a little more relaxed when we're treating just to reduce bleeding risk. So these are the main treatments we have available. So hydroxyurea medication, been around for a long time. It's a classical cytoreductive therapy, technically a low grade, low dose form of a chemotherapy. It slows down or blocks the division of cells in the bone marrow. So it lowers all of the blood counts, the white, the red, and the platelets, causes the red cells to be a bit large as a normal, so that's expected with hydroxyurea. Reduces spleen size, can help with some symptoms, reduces risk of thrombosis and bleeding. Generally pretty well tolerated. Side effects include mouth sores, skin changes, leg ulcers, rare complication. Over many years, we think there may be an increased risk, small, of some types of skin cancer. So not the melanoma, the most serious, but the squamous and basal cell can lower all the blood counts. Another option we have is pegylated interferon. People like this in that it's not a chemotherapy, but it also lowers all the blood counts, which can be a good thing or a bad thing, depending on how much it does it. Similarly, reduces thrombosis, helps with symptoms, reduces spleen size. Some people, we can see a reduction of allele burden, maybe, let's say maybe reduce the risk of progression. Slow acting. So for benefits of interferon, takes longer to improve the blood counts. And for these longer benefits like improving the bone marrow, reducing allele burden, we're talking years on therapy. It's a subcutaneous injection, generally a little more difficult to tolerate with side effects than hydroxyurea, but it's very variable between individuals. And as I mentioned, there are two forms of interferon. There's the interferon alpha 2A or Pegasus, and this is actually Ropeg interferon alpha 2B. The Pegasus is available in Canada. There is a study comparing to hydroxyurea showing similar responses at 1 year. So it's a reasonable alternative to hydroxyurea when funded, if funding is available. There is also a new form of interferon, the Ropeg, that is hopefully will be available in Canada soon, but is only approved in the US and Europe. It was studied primarily in PV with the large studies comparing to hydroxyurea and showing similar outcomes to hydroxyurea in the intermediate term, and hopefully some added benefits long term, but still to be determined. The studies in ET are limited. There was a study that was done in ET that had Canadian sites across the country. And so some people were able to access the medication through that. Overall, it's thought that these two medications are pretty similar. The biggest difference is the Besremi dosing interval the usual is every 2 weeks, whereas Pegasus is every week, although many people on taking Pegasus long-term do dosing at longer than 1 week intervals as well. And finally, there's a medication called anegrolide, which is a tablet. It's not very widely used. It only lowers the platelets, not the white blood. It does reduce the risk of thrombosis and bleeding, but there was a big study in the UK a number of years ago that showed it's less effective overall than hydroxyurea. Its side effects more difficult to tolerate, headache, palpitations, diarrhea, and it may actually increase the risk of fibrosis in the bone marrow. So in some people, but so it's definitely it's always good to have options. It wouldn't be the first choice, but if a person can't take hydroxyurea, then it is an alternative medication. And finally, there are the other group of medicines I wanted to mention were the JAK inhibitors. So the JAK inhibitor in Canada, most widely available, is called ruxolitinib. It is approved, funded, and widely used in myelofibrosis and polycythemia vera. It is not approved or funded in ET. And the reason why is the biggest study called the Magic ET study, which enrolled people who were resistant or intolerant to hydroxyurea and then randomized people to either ruxolitinib or what we call best available care. It didn't show any difference or benefit for the ruxolitinib with the endpoints of controlling the blood counts or reducing blood clotting, bleeding, or progression. There was some improvement in symptoms with ruxolitinib, but because these other things didn't show a benefit, there wasn't a path forward for regulatory approval and funding. There are some ongoing studies still with ruxolitinib in ET, but at present, it's not approved or funded therapy. It's not approved anywhere for ET, and it's not funded in Canada for ET. So that concludes the part about the treatments that we have available or treatments that are established. I do want to talk just briefly about where we might go, what might be coming in the future, because that's always pretty exciting to look about, what we may have coming down the road. And the first thing I've got to say is that there are not as many new treatments that are being studied in ET as there are for MF or polycythemia vera. And part of that just relates to the people with myelofibrosis. The disease tends to be more symptomatic and progress more quickly. So there tend to be more studies in that patient population. And to some extent may be true with PV as well. So it's because of those reasons, ET is less studied. But on the other hand, some of the treatments that work in myelofibrosis and PV will likely work in ET too. So the studies there can still be relevant. But I'm going to talk here just about the studies that are in ET. So the medication that's furthest along at being studied in ET is bormedemstat, and it is an LSD1 inhibitor. So this is back to our cell signaling pathway. So it works at a different spot. So to help to block the overactive growth and proliferation of cells. So still in the same signaling pathway, but a bit deeper in the cell in the nucleus. And there has been a published phase 2 study. So last year in 2023, presented a study with patients resistant or intolerant to hydroxyurea. And they took the medication for 6 months. And in 94% of patients, the platelets were under 400 with no thrombotic events or serious complications. And there was improvement in the MPN symptoms as well. Now, 14% of patients did have to discontinue, often related to side effects, which included changes in taste, constipation, and joint pain. So some promising preliminary results, but additional studies needed. And there is an ongoing phase 3 study that compares the medication to best available care. And so hopefully we'll get the results of that in perhaps within the next, I don't know exactly when it's going to read out. It takes a while for these studies to be completed. And then the other really exciting area is targeting the CALR. So the medications we've talked about before, which target that JAK2 signaling pathway, they work in people who have the JAK. It doesn't matter if you have the JAK2 mutation or not, because for everyone with ET, that signaling pathway is overactive. With these medications, it is only for people who actually have the CALR mutation, because it is an antibody specific against that mutant protein. And this is being tried in people with ET and with myelofibrosis. And so having an antibody against this calreticulin protein that's on the surface of the cell. And there are also other types of antibody treatment where they link this antibody to a T cell receptor. So this would be a bispecific antibody. So it tries to bring in a T cell to target the abnormal blood cell. This is a therapy. The mechanism, this bispecific modality, is used for other types of blood cancers. And then finally, there are not in people or clinical trials yet, but in mouse models and animals, they are working on developing a CAR T treatment targeting the CALR mutation or CALR protein. And these CAR T treatments, you may have heard of them for other types of blood cancers. So that's where they take some blood and they use a person's own T cells to manufacture a T cell that will target or attack a certain target. Very, very early days in myeloproliferative neoplasms, not in people yet, just in mice, but it's really exciting proof of concept because this is a different modality of treatment, which I suspect, because it has certain side effects, would likely be tried first in people with myelofibrosis, but in time, if it works and is tolerated, may expand to other populations with the CALR mutation. So thank you very much for listening, and I think I'll hand it back over to Natasha.
Thank you, Dr. Foltz, for sharing your insight and expertise today. It's now time for our question answer period. So if you haven't done so already, please be sure to use the Q&A box in your Zoom webinar panel to type your questions. And as we mentioned earlier, due to the large number of participants and our limited time together today, we might not be able to answer all of the questions. I'd also like to note that Dr. Foltz cannot answer specific questions about a person's health history or status. Dr. Foltz, our first question for you here. Would someone living with ET who has also experienced other solid tumor cancers be more likely to evolve into PV? And if so, what should we watch for?
So good question. We don't know we don't know that that would be a higher risk. So that's not something that has been described as a risk factor for disease progression from ET to PV. That being said, it is important for everyone to be monitored for any sign of progression or change of the ET. As I mentioned, for most people, it stays stable and never changes, but important to monitor for that. And the ways to monitor for that would be with your routine blood testing. So if there was a sign of the disease progressing or changing either to PV or myelofibrosis, it would usually show up with changes on the blood counts, which your doctor would be monitoring anyway. If the disease is progressing towards myelofibrosis, sometimes people can notice enlargement of the spleen with discomfort on the left hand side, increase in night sweats, increased weight loss. So, if there are changes in your health, then you, of course, want to discuss that with your doctor as well.
Great, thank you. And then we have another question here. Is there a difference in the probability of transitioning to AML for those with ET versus with post-ETMF?
Yes, the answer is yes. So, if a person develops post ET myelofibrosis, so if it transitions to myelofibrosis, once it's at myelofibrosis, then there is a higher risk, unfortunately, of progressing to leukemia. That being said, with myelofibrosis, there's still a wide range of risks, and there are a number of other prognostic scores and factors that we would look at to determine for an individual what their specific risk is. But the answer is if you're at post ETMF, the risk is higher than for someone who has ET.
And staying on that topic of ET, how robust is the research in seeking a cure for ET?
Cure is really it's challenging. So the and that it's what we would all look for is a medication or treatment that can cure. And by cure, what we're essentially meaning is eliminating that abnormal cell with the mutation. So that is what we are trying to do with the treatments, but it's difficult to do.
Mhm.
So the research is there, and I think with the similarities between MF and polycythemia, it's hopeful that some research being done in the related conditions, if successful, could also be applicable to ET.
Thank you. I think we have time for a couple more here. Quebec had interferon, sorry, I don't know if I'm
Mhm.
pronouncing that right, for ET since the 90s, but it has since disappeared in 2021. Do you have any insight into that?
So there are similar but different medications. So there is
Mhm.
in one called or historically has been a one called interferon, and there are different types of interferon. So there's interferon alpha 2A, interferon alpha 2B, and then there is pegylated interferon alpha 2A and ropeg interferon alpha 2B. Okay, so it's like the alphabet soup of medications. The his the issue with interferon, the problem was the manufacturer stopped producing it. The issue with interferon and with Pegasus to some extent is that they were originally designed for treating other diseases, but they're not currently used for treating the other conditions. So the original indication or reason for making the drug doesn't exist anymore. And
Mhm.
so the manufacturer made a business decision to discontinue interferon. So now the only compounds we have more readily available are the pegylated interferons. They're similar but not the same. They're more longer acting, on average have fewer side effects, but it is of course individual. So the short answer was unfortunately the manufacturer discontinued producing interferon. And now we have PEG, interferon, and ropeg to some extent.
And then our next question here, have you ever seen concurrent liver function changes, or is there a relationship between ET and liver function?
Mhm. Um, there can be. Uh, so, but it can be complex. So there are complications from ET, such as blood clotting, which in the abdomen, which can affect the liver. Um, there are some situations, and less common with ET, more common with myelofibrosis, where the abnormal blood cells that we often see collect in the spleen can collect in the liver, causing some mild liver inflammation or elevation of the liver blood tests. And then sometimes we can see liver inflammation as a side effect of the medications we use to treat ET. So it can be related, and those are all the types of things that we would be considering.
And then just one last question. Can women entering menopause with ET CALR type 2 use estrogen transdermally?
So that's a really good question. So the concern is that with ET, there's an increased risk of blood clotting. We, of course, do all the things we talked about to minimize that risk, but there still is an increased risk. And there has been concern that with hormone replacement, it can be associated with an increased risk of blood clotting. Now,
Mm.
the transdermal estrogen has the lowest risk of any of the estrogens, and some studies suggest increased risk of clotting with that is pretty minimal. So it really ends up being a risk benefit decision based on weighing out how severe the symptoms are and what a person's individual risk factors for blood clotting are and what the benefits to them of using the estrogen would be. So for me, it's an individual discussion. But if we are going to use estrogen, I agree the transdermal is the best, and we'd always want to use the lowest possible dose that someone gets benefit from.
Well, thank you so much, Dr. Foltz, for the Q&A and for your time today. Your expertise and insight is very valuable for for us as a community. Thank you everyone for attending. I'd like to invite you to join us for our last session of the National MPN Week Conference tomorrow, February 27th, taking place at 1 p.m. Eastern Standard Time. Our topic, Understanding Polycythemia Vera, Diagnosis, Treatment, and Follow-up Care with Dr. Sarkozy. We would also like to take a moment to thank Forest Therapeutics, Pharma Essentia, and GSK for their support in making this event possible. Please remember, we are here to help you. You can reach out to us by email, by visiting our website, bloodcancers.ca, or by calling us toll-free. Please note that we will be sending out a short survey to all participants after this presentation. Please take a moment to respond as it helps us plan for future events. Thank you for being with us today, and everyone take good care of yourself. Bye for now.